Yeah, availability in the accessibility or opportunity?
No,
opportunity.
Okay.
Yeah, okay.
Yeah.
Before Pacific was performed, immunotherapy had already kind of reached the level of standard of care in advanced disease. In the recent 5 years, I would say in lung cancer, a little bit longer in melanoma, maybe 10 years in melanoma, immunotherapy has been shown to be able to really improve the outcome of patients who suffer from metastatic disease, a palliative setting, right? In lung cancer, it started with late-line treatments, second-line treatment, moving to front-line treatment. But in this scenario, to my opinion, every advanced disease, non-small cell lung cancer, should receive immunotherapy at some point because it really improves the outcome and allows for a long-term benefit in a small proportion, but significant proportion of patients.
We have now 3 drugs for the treatment of second and third lines in non-small cell lung cancer. And the drugs are nivolumab and atezolizumab for all comers, so you can administer the drug independently by the PD-L1 expression. And you have also pembrolizumab, which is approved for patients with PD-L1 more than 1%. So the question is if you select with the PD-L1 expression or not. There are things in favor of this and things against. What it is clear is that there are several evidence that all the drugs work also in patients with PD-L1 less than 50% and atezolizumab and nivolumab also for patients negative. And I have also in my personal experience patients with PD-L1 very negative experiencing very long-lasting responses. So I think that the use of PD-L1 in second line is not so mandatory as in the first line treatment. What I think it can be important is the history of smoking of the patients, because if you look at the subgroup analysis of all the clinical trials, you can observe in all the clinical trials that patients never smokers benefit less of immunotherapy compared to patients current or former smokers. So the use of immunotherapy in second line for patients never smokers must be discussed with the patients because potentially they have other treatment options such as, for example, docetaxel plus anti-angiogenetics or something like that, or also docetaxel or also other drug, because there is no clear benefit of this kind of patients with immunotherapy. We have 2 important randomized clinical trials suggesting that there is also a role of docetaxel plus anti-angiogenics. The 2 drugs are ramucirumab and nintedanib, and they work better than docetaxel alone. So this is another important option for second-line treatment of non-small cell lung cancer. When can we decide to use immunotherapy or the combination of these 2 drugs is another open question because there are no randomized clinical trials comparing the 2 strategies. So this is an important decision that must be shared with the patient because the combination of chemotherapy plus anti-angiogenetics is totally different from immunotherapy, but can be an important option for patients who have an early progression with the first-line treatment, because we have in all the subgroup analysis the idea that patients with early progression can benefit more from chemotherapy plus anti-angiogenics. So we can decide to go with chemo plus anti-angiogenics and then immunotherapy as a third line, or we can go with the first-line chemo, immunotherapy, and then to use again chemotherapy as a third line. There are no clear answers to these questions, so I think that we have to share the decisions with the patients, patient by patient, according with the toxicity and also with the expectations that we have from the drugs.